Sprains and strains are often used interchangeably, but there is a difference. So ligaments connect bone to bone and tendons connect muscle to bone. When you're thinking of traumatic injury to soft tissues, it's graded according to severity. A sprain is an injury to the ligaments around a joint, and if the ligament is stretched too far, it can tear. There are first, second, and third degree sprains, depending on the degree of tearing and the damage. Third degree is the worst, with complete separation from the insertion onto the bone. The degree of the sprain is determined by clinical exam and guides the treatment, which can be anything from rest to casting up to multiple weeks, like a bone fracture. The older the patient, the longer it will take to heal a sprain, and a severe sprain may require surgery in the older patient. So grade 1, a first degree sprain, the ligaments connecting the bone are often overstretched and damaged microscopically, but not actually torn. The ligament damage has occurred without any significant instability developing, and mild tenderness can be noted. In a second degree sprain, you can see injury is more severe and indicates that the ligament has been more significantly damaged, but there's no significant instability. The ligaments are often partially torn. There tends to be lots of swelling. There may be ecchymosis and usually trouble with the joint where they're not able to walk on the knee, or an ankle sprain. Third degree, again, is the most severe. It indicates that the ligament has been significantly damaged. Instability has resulted. A grade 3 injury means that the ligament has been torn, and due to this complete ligament tear, hemorrhage, instability of the joint, inability to perform active range of motion is common, and it tends to be very, very painful. Strain, pull, or tear is the damage to muscle itself. Also can be damage of the tendons, usually includes bleeding with bruising seen on exam. Fractures are more common in pediatrics. They include 10 to 15% of all pediatric injuries. And it's important to have be aware of special considerations with pediatrics. This could include preosseous cartilage and the physeous growth plate. They tend to have a thicker perosteum and produces more callus. They tend to be more rapid healing at a younger age, and healing does slow with age. Fracture remodeling is ineffective and tends to be particular in displaced intra-articular sites and with fracture malrotation. Operative treatments in kids, they can use different techniques and hardware is always removed after healing. It tends to just help with anatomical alignment, and it's more important than rigid fixation. The classifications of fractures include complete, which would be both sides through the cortex on both sides, a buckle or a compression fracture, a green stick, which is a spiral or a rotational fracture. You have to be aware of abuse, because we all are mandated to report abuse, and it's important to be aware of that. Bowing or a bend fracture, that is where a deformity is seen, and it's not really a fracture, but it can be seen on x-ray. You could have an open or a closed fracture. Open would be coming through the skin, closed would not be coming through the skin. Displaced fractures, where the fracture site is moved so that end-to-end contact is not maintained. You could have a stress fracture due to overuse, or insufficiency, which is abnormal bone fractures from normal use. With pediatric fractures, sometimes a long bone fracture is seen in a bayonet style with overlapping ends. Repair is so vigorous in children that the healing or the fractured bone may wind up being longer than the contralateral side, so the bayonets overlap, and that'll allow both sides to remain equal at the end of healing. Bayonet knife is fixed to the rifle when it's time to charge the enemy. It overlaps the rifle, and a fracture is seen in a very similar way. Epiphyseal fractures, these occur with the peak incidence in males at age 13 to 14. Girls are a bit younger, 11 to 12. They do tend to be more common in men or boys, and more common sites are the distal radius and then the distal tibia. These classifications can be broken down more by a Salter fracture. Those can range from class 1 to 5. The more poorly aligned or crushed, the higher the level of Salter, and more likely will need open surgical fixation. Management here is injury. Injury to the growth plate is the thing that you're most concerned about, and you're always required to give an orthopedic referral for ongoing management, and make sure to be aware of the nerve roots and foot drop if there's too much cast pressure when the cast is placed. Special problems with fractures include neurovascular injury. That would be more with the distal humerus or supracondylar fractures or the knee. Compartment syndrome, which is hemorrhage and a lack of blood supply. It could be caused due to the way the cast is placed. Toddler's fracture, which is a distal tibia fracture. That could cause limping, but you can't see the fracture on x-ray. And you may need to do a bone scan to verify that type of fracture. Again, be aware of child abuse, the green stick fracture, or even shaken baby syndrome, where you'll see a metaphyseal corner fracture. And these would be more in long bones, humeral, tibial, femoral shaft. If suspected, you need to admit the patient and do a bone scan to look for possible older fractures, and of course, refer to a specialist.